Okay, class, welcome back. In this series of lectures, we're going to talk about pulmonary rehabilitation. So, pulmonary rehabilitation, I think, is a nice way to kind of segue off some of the things we talked about with airway clearance and ventilatory strategies. Um, and pulmonary rehab, and we'll get into some of the definitions, is really where a lot of this stuff kind of comes together in a formalized manner for patients with different respiratory issues. Now, we'll go over kind of what pulmonary rehab entails, some common interventions you might see or approaches to training. We'll go over the patient populations you might see, the benefits, the evidence, and how some traditional pulmonary rehab techniques may be beneficial potentially in orthopedic rehabilitation. And we'll kind of get into a little bit of respiratory muscle assessment and training. It's a lot of what I actually do as a researcher and as a clinician, primarily in bariatrics, which is kind of a bit of a grab bag or mixed bag of things. So again, we can't escape it because again, it's my favorite model in physiology is the Whipple-Wasserman gas exchange gear. So again, if we see changes in one of these cogs, right, whether it's muscle, the peripheral muscle, circulatory cog, ventilatory cog, one of these will have to work a little bit harder. Now, as we know in pulmonary or respiratory disease, whether it's obstructive or restrictive or chest wall, maybe infiltrative, sort of like a pneumonia of some kind, right? This ventilatory cog's not going to be working as well. We're going to throw a wrench basically in that system. We know that we're going to see changes to the vasculature, pulmonary vasculature, and then maybe potentially the right ventricle in patients with various pulmonary conditions. And we often see changes in the muscle, right? And we'll get into some of the we got into some of that with the diaphragm and the diffuse muscle wasting. We also see in the peripheral muscles. How the kind of the other important side of this is, when patients have pulmonary or chronic pulmonary conditions like your COPD or IPF, we're probably not going to fix this. That's not going to get corrected. So how do we then improve the ability for people, right, to exercise, right, to produce, the consume VO2 and expel VCO2 in order to fuel the metabolic machine of our body to produce human movement. We accomplish that by beefing up the periphery. So again, similar to our cardiac rehab unit, that we're probably not going to correct. So for the heart failure example, we're probably not going to correct what's happening in terms of these central changes to the lungs. In this example, in pulmonary, we're not going to change the central changes, but we can improve extraction of oxygen, we can improve strength, we can improve other components in the peripheral muscles and potentially the respiratory muscles to offset changes in the pulmonary side, the ventilatory pump or the ventilatory cog here. So a lot of what pulmonary rehab is geared towards is improving the strength of this cog to offset the changes that occur centrally with the lungs. And as you'll see, a lot of the things that happen with pulmonary rehab, they're not going to have any effects or much effect on lung volumes, say for maybe smoking cessation and just different things to avoid making the condition worse. The improvements are going to come from changes in the periphery, and we're specifically talking about the muscles here. Right? So again, just a review of some of the physiological changes that happen with pulmonary disease. We may see that phase switch to type 1 to type 2 in the peripheral muscles. Maybe some of that is due to disuse atrophy. We also know there's widespread inflammatory changes. Mitophagy may be involved. We see selective changes in the mitochondria in these type 1 cells. And we see, overall lower amounts of mitochondria, decreased density mitochondria. We see higher energy expenditures, and we also know they often have difficulty breathing and difficulty eating related to their breathing and some of their disease. So they have this catabolic or caloric imbalance or caloric deficit because of the higher energy expenditures, which are due to the increased demand of breathing. And if they're not consuming calories, are going to be an energy deficit, and we end up seeing reductions in free fatty mass or muscle mass. So again, there are some very unique physiological changes that happen to the muscles specifically in patients with pulmonary disease. The good thing is that's if there's deficits, there's room for improvement, right? So or I guess maybe not a good thing, an underlying silver lining, right? So where there's deficits, we can always make improvements. And again, we see wholesale changes to the lungs. If we're looking at restricted diseases, lung volumes just get smaller, the lungs get more fibrosed, and just they don't expand as well. And obstructive defects, again, we see the lungs typically get a little bit larger. We're holding on to more air. See a lot of increases due to residual volume. We're trapping air. We're holding on to more air. We can't get air out efficiently, right? So, and then specifically with patients with COPD, we see that dynamic hyperinflation where they get to a point, because we're speeding up ventilation during exercise, they get to a point where they start holding on to more and more air, right? Because they have that flow deficit or velocity time equation, right? They can't get enough volume out over a period of time, so they keep holding on. If we decrease time, we hold on to more volume. So they can get to these points where their lungs are just so full of air they can't even take it anymore, right? So that dynamic hyperinflation due to an expiratory deficit. So again, dynamic hyperinflation in a patient with obstructive defect, they have problems getting air out, especially in a short period of time. If we decrease that time, they'll hold on to more air each breath, and they'll eventually get to a point that expiratory limitation has also led to an inspiratory limitation, because there's just no more room to take air in. So they've got some physiological changes here, and we touched on this. If you want a little bit more review of that, touch on our chronic pathophysiology series. So common impairments. So we talked about physiological changes or disease level changes. Now let's get into functional limitations and impairments. This is really what we kind of work with and what we're assessing as PTs. So we often see reduced exercise capacity, which could be assessed on a 6-minute walk test or cardiopulmonary exercise test. We see reductions in strength, which will make sense with some of the things that we see in terms of the skeletal muscles that disuse atrophy, as well as some of the almost like the myopathy that we sort of see in these patients. We see impaired balance. They have a high fall risk. Some of that's due to inactivity. We'll also go over maybe some other underlying issues that may be involved in patients with COPD specifically. Dyspnea, very minimal activity, and that dyspnea can often feed into anxiety, which can make their breathing even worse, right? If you get a negative, if you have, symptoms of very minimal activity, it's going to make you more anxious and maybe avoidant of participating in activity due to those past experiences of dyspnea. So we can see these sort of things feed into each other. There's negative experiences leading to anxiety about activity, leading into even less activity and further worsening, their overall risk profile and risk of mortality. Reductions in gait speed, reductions, or impaired cardiorespiratory responses to exercise. We see ventilatory efficiency, so they require a lot more breaths per minute to move out the same amount of CO2 or take in the same amount of oxygen, which makes it very, very inefficient during exercise. And then we also see a higher number of back pain and chronic pain in patients with COPD. Some of that's probably due to the inflammatory changes, which impair their ability to down-regulate pain. We also see a protraction of the respiratory center, which we think is kind of connected to pain. So often if those are kind of wound up, can kind of make people a little bit more, or make it harder for them to control their pain. And then, if you're inactive, you're not sleeping well, that also contributes to the back pain. Patients with chronic lung disease often have disordered sleep. Not too uncommon. And then, of course, maybe there's some biomechanical changes that happen, especially in long-standing COPD. So there's a multitude of different things that may contribute to their pain. So again, knowing all these things, well, what do we do here to improve this? Like these aren't things that can really be affected or improved by medications. It can be improved by exercise, but we need to have maybe something a little bit more unique for patients with respiratory disease. So this is what pulmonary rehab is. Pulmonary rehabilitation is an evidence-based, multidisciplinary, and comprehensive intervention for patients with chronic respiratory diseases who are symptomatic and often have decreased daily life activities. It's integrated into the individualized treatment of the patient. Pulmonary rehab is designed to reduce symptoms, optimize function, increase participation, and reduce healthcare costs through stabilizing or reversing systematic manifestations of the disease. So we're not reversing the disease, we're reversing all the impairments related to the disease. Comprehensive pulmonary rehabilitation programs include patient assessment, exercise training, which is kind of like the engine room of the program of these programs, education, and psychosocial support. Again, we mentioned again some of the mental health, the anxiety issues that kind of ensue from having any chronic disease, especially relevant in patients with pulmonary disease. So really kind of what is it, right? So pulmonary rehab combines, again, exercise training, behavioral, and educational programs really to help patients with lung disease. That's a way to kind of think about it. It's ways to improve their ability to perform day-to-day activities with less symptoms, or give them tools to maybe mitigate their symptoms. So we'll go over some of the things that we often do in these sort of programs. The great thing about pulmonary disease, it is pretty effective and for a lot of different conditions. We see it's great at reducing respiratory symptoms, or again, those manifestations of disease, which are dyspnea and fatigue. We see those often get a lot better because their muscles get more efficient. We also teach them strategies to control their dyspnea, or maybe conserve energy so they don't get as fatigued. We can improve muscle strength and endurance, make it easier for them to get around. And even just having a better knowledge about your disease, right, can really help you better manage it, right? You know things to avoid. You know maybe to wear a mask, or if you're around particulate and stuff like that. Different things different things that you can do to make them have a little bit more agency in controlling and managing their symptoms and condition. And then probably the big thing is PTs, like able to perform ADLs a little bit better, increase quality of life, decreasing depression and anxiety. Again, if we can make people a little bit less breathless with exercise and activity, that's going to decrease their anxiety about activity. And that's huge, right? As well as if we can decrease shortness of breath as well. We also see reductions in exacerbations and decreased health resources. If people are a little bit more resilient, right? If we get their bodies a little bit stronger, they're less likely to have acute exacerbations of their conditions, right? And in some cases, we can even get people to return to work, and most often return to maybe just leisure activities, like stuff that they were not able to do, like maybe walking around the block, or with their partner, or getting back to activities they enjoy. It's just like anything in rehabilitation, getting people back to doing the things they like to do, and doing so safely. So again, the objectives of pulmonary rehab, again, were to control and to alleviate symptoms due to pulmonary diseases, to optimize function, improve exercise capacity, improve independence. We're trying to make people more physically active, to learn more about their disease, treatment options, and coping strategies, right? Are we going to reverse the disease process? Probably not, right? We're not going to reverse the disease, right? But we can decrease the symptoms and disability related to the disease, right? By addressing some of those physical impairments that they often have, such as impaired muscle strength, impaired endurance, dyspnea, different stuff like that. So again, we're not going to probably reverse the disease process. They'll still have COPD, but we can allow them to be a little bit more functional, a little bit more independent, have less symptoms, less disability related to their condition. The target populations that we see with pulmonary rehab, we have those listed to the left, COPD, GOLD classification 2 through 4. Typically, we want to see these in patients a little bit more moderate stage and beyond. Obviously, patients with interstitial disease like IPF would be eligible, bronchiectasis, anyone after a lung transplantation or a lung volume reduction surgery like a lobectomy, and then realistically, it's any stable patient with a respiratory disease or chronic lung disease, or after an acute surgery could be eligible for this, right? So, or acute thoracic surgery could be eligible for this. So it's anyone with these conditions who are limited due to their respiratory condition. We want stable patients, right? That's kind of similar to what we see with cardiac rehab. The patients typically want them to have a PFT within a year. Again, that's a way for us to determine stability as well as to stage their severity, right? Are they class 2 or above, especially if we're looking at COPD. There's an inpatient setting to this as well as outpatient. The focus of this lecture will really be on the outpatient side, inpatient rehabilitation. Again, the goal really there for inpatient practice is get people kind of discharged out of the hospital. So, and again, we talked about the components: assessment, training, nutritional intervention, and psychological support. So again, it's a multidisciplinary team. Again, we're really focusing on the outpatient side, but it's going to involve physicians, nurses, respiratory and physical therapists. In countries outside of the United States, there really aren't respiratory therapists. They're just physios who specialize in respiratory care. So you might see different things depending on the country. Obviously we're going to attend to the individual's needs, goals, just like we do with anything in rehabilitation. It's a combination of kind of our expertise, the patient's individual goals, and best practice. And then trying to address, again, psychological, emotional, and social issues that may be related to the condition, that we can maybe intervene with the right professions or services. So again, just a little bit more about the interdisciplinary team. We'll see the patient obviously is number one. The medical team, so usually a medical director, which is a physician. I think some states in the United States are looking at maybe having nurse practitioners or PAs involved, but most places it'll be a physician. A physical therapist, again, depending on the setting, depending on the country. You may see respiratory therapists. We're going to see respiratory therapists involved in outpatient pulmonary rehab in the United States. You'll see nurses, occupational therapists, social workers, nutritionists, again, because nutrition and caloric intake is such a big concern in patients with respiratory conditions. And then psychology and psychiatry services, one, to manage some of the mental health issues, as well as maybe addressing some of the anxiety and just education, maybe smoking cessation programs are there as well. So this is kind of things that that are provided in a pulmonary rehab program. So medication optimization is making sure people are on the right meds, adjusting oxygen needs as needed. Some patients may need one level of oxygen for what they do at rest. They may need a little bit different during exercise, and a pulmonary rehab setting is a great way to kind of figure that out, because you'll be exercising and they'll be monitored. We'll go over different things they can do to keep their lungs clean. We'll go over smoking cessation. Exercise. We'll go over respiratory muscle training, endurance, breathing retraining. You might see as well to give people, conscious cues they can do to help kind of control their symptoms. Energy conservation techniques, psychological counseling, nutritional counseling. A lot of times patients are given supplements for protein, like a Boost or Ensure, just to kind of get their calories up, get their protein up. Especially if they're undergoing exercise, we need protein to facilitate, protein synthesis, right? So we need to take, or muscle protein synthesis, MPS. So we need to, have adequate nutrition to really get the best bang for our buck of exercise training. And then, usually when patients are discharged, they'll have a maintenance program. So once they complete a formal program, they'll range between 4 to 12 weeks. Often patients, just like in cardiac rehab, can come back and be in a safe, supervised area where they can exercise. The programs will typically comprise of initial assessments, the underlying medical condition. We'll kind of get a better understanding of what's actually happening to this patient, a general assessment of their just current status, and then where we really kind of come into as PTs, and maybe you haven't seen an exercise physiologist or nurse involved here, or respiratory therapist, is this assessment of their functional goals. Like what are they able to do? What do they want to get back to doing? What are their goals? We'll establish our rehab prognosis, just like you would anywhere in rehab, and then determine their goals. Like what are their goals, which will be a combination of the patient's goals and then your goals for therapy, right, for rehabilitation. And again, we got into practice settings. Hospital-based, could be a private outpatient clinic, physician oversight. Most places in the United States are hospital-based. In physical therapy practice, you can see often, just in a typical outpatient PT clinic, you can see patients for PT services depending on the state for pulmonary rehab. We were doing this sort of at UIC for a little while. It wasn't a formal program, but patients were enrolled. I have colleagues on in Oklahoma that were seeing patients in an outpatient PT clinic for pulmonary rehab. So unlike cardiac rehab, where you really probably need to be affiliated with a hospital-based system, pulmonary rehab, at least still in the States, you can still probably get by even just seeing some of these patients in your outpatient clinic. Then there may be even home-based programs where you're delivering interventions through a telehealth platform, or maybe for lower risk patients for maintenance programs, walking programs they can follow at home. Now, in terms of settings, like I mentioned, plans of care will range typically between 4 to 12 weeks, 2 to 3 times per week. The optimal duration really isn't well known. There's large variability among centers and how they do it. Longer durations typically seem to work a little bit better. The effects typically last longer. People continuously participate in exercise. That's not surprising. And it's ideal if a clinic has their own oxygen supply. That's kind of why you see most centers, at a hospital, because they have, wall oxygen, they have an unlimited supply essentially. A little bit harder to do in an outpatient clinic, but patients sometimes can bring their own. It's just something I kind of have to work out, but it's kind of why we see patients typically go to hospital-based clinics. Sessions usually last 75 to 90 minutes, and that's really to build in this rest-work ratio, so the patients can, we want to make sure they have an adequate time of resting between exercise, just so that we can prevent them from going into an acute dyspneic event, which could make things even worse. So if we can kind of give them an adequate rest break and let them get through their session of exercise. Most patients, a goal will be to maintain oxygenation above 90%. It might be lower for some patients, and usually that's the conversation you have with the medical director of their facility and the referring provider. Limitations, though. It's not a guarantee that not all patients get referred. We have the same problems like we do in cardiac rehab. There was a study that was done by Tratham et al. That looked at 427,000 cases of COPD. 14% of those cases had demonstrated weakness, right, like significant limitations. Less than 1% of those cases received pulmonary rehab services, right? Maybe they referred to an outpatient clinic for something else, but still, that's a pretty alarming number that a lot of people just with these conditions aren't enrolling in pulmonary rehab. Some of it we think is, a lack of just people being aware, similar to what we saw with cardiac rehab literature, but it's a big problem. So, I think PTs can see some of these more lower risk cases. Again, you have to work it out logistically, but it's a very underserved population, and we know we can make very significant inroads. And some of the limitations, we think maybe just a lack of people being able to get a PFT and readmission. So maybe there are some guidelines that impact this, or policy issues. And if patients get readmitted, that may affect their ability to participate. But again, it's a big problem. A lot of patients aren't referred. And this is despite that the evidence for pulmonary rehab is pretty good. It's been suggested that, this goes back, I think 2014, Cochrane, database, Cochrane's systematic review and meta-analysis suggested that additional randomized controlled trials, right, for pulmonary rehab for patients with COPD aren't even needed. We know it's safe. We know it's effective, right? We don't need to justify if, is the mechanism there? Does this actually improve patients with COPD? Is it helpful? We know it is. We know it's safe. We know it's effective. And all future research now is focusing on identifying, well, how do we make it even better? Right? What's the ideal length? What's the ideal location? Level of supervision that's needed, the intensity of training, and how long treatment effects actually last. Because we know it works, we know it's safe. We got to find the best delivery model. Just what can we tweak for each individual patient to make it the most optimal experience. So, which is, I think, is you don't see those kind of statements from a lot of interventions. We don't even need to investigate whether this is effective anymore. We know it's effective. And it's kind of interesting when you compare treatment of inhaled bronchodilators. Pulmonary rehab has a greater improvements in health-related quality of life and exercise capacity, which makes sense because you are improving exercise capacity with training. But it's pretty strong findings that you're going to make significant inroads, and that like I mentioned, one of the big issues of patients with chronic lung disease is acute admission, getting hospitalized for an exacerbation. So we're finding that pulmonary rehab reduces hospitalizations due to an exacerbation, and even medical visits. So often when we look at when we're looking at healthcare utilization, we look at hospitalizations and acute admission, as well as even clinic visits, right? So getting people a little bit, getting people through these programs, making them stronger, as well as understanding how to self-manage conditions before they become or become worse and needing medical intervention. We can reduce their utilization, which is great for our healthcare systems. We even have evidence now that in patients who do get admitted to a hospital for an acute exacerbation of COPD, if we intervene, afterwards, it helps accelerate recovery. So that's the kind of the next frontier is like, when can we reinitiate pulmonary rehab in patients with COPD who do have an acute admission? Because it does happen, even in the most robust patient. All right. What I find super encouraging, and it's something that has evolved. I started teaching this course back in 2014, and then even as a resident and a lab instructor in Wisconsin back in 2013, there wasn't a lot of evidence. There was a lot of evidence to support pulmonary rehab for interstitial lung disease. It was just thought, like, theoretically this makes sense. It appears to be safe. There was a limited number of trials, and similar to our medications for interstitial lung disease, like idiopathic pulmonary fibrosis, the evidence for pulmonary rehab for this population has grown as well. So now there's extensive growth in this area, and pulmonary rehab is now considered not only just safe and maybe effective, it's considered to be an integral. Let me move my little guy over here. An integral and essential component of the management of patients with IPF and other interstitial lung disease. And it's usually a major feature in most guidelines. And again, if you look back even 5-6 years ago, this wasn't really there because there just wasn't enough evidence. And now we kind of have it. The improvements typically are, just like in COPD, exercise capacity, dyspnea, quality of life. And we see these benefits are typically immediate and short term. They might not be preserved. So like the COPD literature, maybe we need to look at getting people enrolled in maintenance programs or things to keep them active, because if they go through a program, do real well, and just stop being active, those benefits aren't going to last forever, right? So we got to find ways maybe keep them active and keep them engaging in these healthy behaviors. This is kind of where some of the two big studies here. So Tonelli and Shiraha published these two really kind of landmark papers looking at the effectiveness, and prospective models for patients with interstitial lung disease. So again, like you look back 5-6 years ago, the evidence wasn't there, and I'm just really encouraged because it's a pretty significant population as well, and it's always good to make sure that we have resources for them too. So that's pulmonary rehab in a nutshell, what it is, who it serves, and what the evidence is. Again, the evidence is overwhelmingly positive. If we can get patients, especially who have these limitations, and the programs that improve those limitations, they're going to be more independent, right? They're going to be a little bit more resilient to acute disturbances, or acute things that may happen when they're in their communities. So in the next section, we'll get into some of the more nitty gritty of what we actually do when we're assessing patients, and some of the interventions we can provide to patients in pulmonary rehab.